The following podcast is part of a certified educational activity titled Realizing the Potential of Novel Treatment Intensification Strategies for Metastatic Castration-Sensitive Prostate Cancer. The experts' take on key clinical evidence, practical considerations, and best practices for individualized patient-centered care. Access the entire activity and complete the post-test at peerview.com/UDM 860. Downloadable slides and practice aids are also available.
Good evening. Welcome to this peer review program entitled Realizing the Potential of Novel Treatment Intensification Strategies for Metastatic Castration-Sensitive Prostate Cancer. I'm Matthew Smith. I'm professor of medicine at Harvard Medical School and the director of the GU Malignancies Program at Massachusetts General Hospital Cancer Center. Welcome to all of you in the audience, as well as to those participating in this meeting virtually. I'm pleased to be joined by two outstanding panelists, Dr. Sandy Srinivas to my left, and further to my left, Dr. Karim Fazazi. I'm going to begin with a brief introduction and a case to make a very important point about the role of local treatment in patients with de novo MHSPC, and then I'm going to leave the heavy lifting to my colleagues to really talk about exciting new data of systemic treatment intensification in this important disease state. So here's the background. Patients with MHSPC have poor clinical outcomes. We know this from vast amounts of prior prospective data. We know that survival is related to the type of presentation, de novo versus recurrent, as well as the location of metastases and extent of metastatic disease. There's now clear and compelling level 1 evidence that intensification of systemic treatment improves overall survival, but despite that clear and consistent level 1 evidence for improved OS, the adoption of treatment intensification has been poor across the United States and elsewhere. And so we're going to do our very best to change that today to convince you about the importance of intensifying systemic treatment in MHSPC. This is data from the Stampede Experience with ADT alone, really making this very clear point that patients with MHSPC have poor clinical outcomes. These are almost 1,000 patients enrolled in Stampede between October 2005 and January 2014. This is the group treated with the control arm of ADT alone. The median overall survival was only 42 months, and strikingly, time to failure, defined as PSA progression, local progression, or distant metastases, was less than 1 year. The risk for progression was related to sites of metastatic disease. Patients with soft tissue disease, nodal metastases doing the best, patients with bone metastases doing worse, and patients with both bone and soft tissue metastases doing the very worst, as you can see from the graph on the right. You've heard this terminology of high and low volume, as well as recurrent and de novo. And this is data from Charted and Getug 15, really making the clear point that these disease stratifications allow us to project a patient's clinical course. So the expected median survival ranges from about 8 years for patients with recurrent low-volume disease to only about 3 years for patients with de novo high-volume metastatic disease treated with ADT alone. And so this is, and then if you look at the in-between groups, if you have recurrent high volume, the median survival is about 4.5 months. And de novo low volume, 4.5 years, excuse me, and de novo low volume, similarly about the same at 4.5 years. Notably, U.S. hospital registry data has told us that about 56% of low volume MHSPC is recurrent metastatic disease. In other words, recurrent metastatic disease is overrepresented by low volume, and only about 15% of patients with recurrent metastatic disease have high volume metastases. But these are things we should be thinking about when you're meeting your next patient in clinic and considering the role of treatment intensification. This is a summary of most of the data we have from randomized controlled trials looking at overall survival in MHSPC. And these are the ones that have shown consistent compelling evidence for improved overall survival, and I've grouped them according to the intervention. So GETUG 15, charted in Stampede Arm C, looked at the addition of docetaxel to ADT and concluded that there's benefit primarily in the high volume subgroup. Latitude and Stampede Arm G looked at the addition of abiraterone to ADT, noting that there's similar benefits across different risk groups. And then a number of studies have looked at anti-androgens, Arches, Enzamet, and Titan, looking at enzalutamide and apalutamide respectively, again showing consistent OS benefits across different risk groups. And we now have data from the triplet trials that Dr. Fazazi will describe in his presentation with Aerosens and PEACE-1, showing that triplets of ADT, docetaxel, and either darolutamide or abiraterone improve survival compared to ADT and docetaxel alone. So I'm going to leave the heavy lifting in describing all of these really elegant studies of systemic therapy to my colleagues, and I'm going to focus on the issue that we shouldn't overlook, and that is the role of prostate radiation to patients with de novo metastatic disease, because we have evidence from Stampede Arm H that the addition of prostate radiation to ADT improves survival, at least in the low volume subgroup of patients with de novo metastatic disease. But there has been poor adoption of intensification of systemic treatment in this important disease state. In a population-based study of men in the US, for example, with de novo MHSPC, only about 12.7% of patients receive intensified systemic treatment. You might argue that this was now a few years ago when we didn't have the vast evidence that we currently have, but this was at a time where there was at least evidence for docetaxel and abiraterone. And another analysis from the Veterans Administration claims data reported that most patients with MHSPC who initiated treatment between 2014 and 2018 were treated with ADT alone. And if you leave the meeting with only one message today, it's really that ADT alone is insufficient for nearly all patients with MHSPC. So here's the data supporting the role of prostate radiation in de novo MHSPC. This is from the Stampede trial, showing that, at least in the low volume subgroup, there's an overall survival benefit for prostate radiation. In the high volume subgroup, there was no observed OS benefit. Maybe it intuitively makes sense, right? If most of the disease is outside the prostate, then radiating the prostate may have less or no role, whereas in patients where a substantial amount of the cancer is in the prostate with only low volume metastatic disease, you might anticipate an OS benefit. A meta-analysis has also been performed, driven mostly by that same Stampede data, but also adding in data from HORAD, showing a significant OS benefit in patients with low volume MHSPC. The hazard ratio was 0.73. And there was a 7% improvement in 3-year overall survival from 70% to 77%. Notably, the magnitude of that benefit is approaching the magnitude of benefit, or similar to the magnitude of benefit that we see by intensification of systemic treatment as sort of one measure of thinking about how meaningful that can be for that selected group of patients. So I'd like to now present the first case, and many or all of you will already have answered this question, this case, in the pre-meeting materials. This is and by the way, I developed these cases. When I say developed, they're actually all real cases from my practice. So if there's wrinkles in the cases or things that might seem unusual, it's just because they're actually real patients, not hypothetical patients. So this is a 56-year-old man with a PSA of 30 that led to prostate biopsy showing extensive high-grade disease with a Gleason 5+4, 4+5, and 4+4. Prostate MRI reported a confluent PIREDS 5 lesion throughout the left peripheral zone, extending from the apex to the base, and a probable metastasis in his right iliac bone. He had a bone scan that reported uptake in that same area, consistent with the bone met in his right iliac bone. He then had a PSMA PET CT that sort of confirmed that metastasis in his pelvis, as well as also identified a second bone metastasis in his cervical spine. So Dr. Srinivas, what do you think of how our audience did and how might you manage the same case?
I think they did pretty well. You know, I think the message here, two messages that I think were very clear that needed to come out was ADT by itself is not adequate, and we need ADT intensification for all patients with metastatic hormone-sensitive prostate cancer. That's number one. And with the Stampede and the HORAD, I think it's clear that patients with low-volume disease do well with radiation. I would actually pick the one with metastatic directed therapy as well. You know, there are clinical trials that are ongoing, but I think with the use of PSMA imaging, we are identifying these small sites of disease. So oligometastatic disease with 1 to 3 sites of mets, radiating the prostate and using your SBRT to radiate these sites of metastasis, especially in a young guy who's 56, is very tempting. We don't know about whether there's overall survival, but certainly it will delay his time to his next therapy.
Kareem, what do you think? How would you manage this patient?
I would pretty much agree. There are several things I would definitely do, and there are several things I would probably discuss or consider in this gentleman. Those things I would really recommend would be systemic intensification with an AR pathway inhibitor, also a local radiation directed to the primary based on what you said in the Stampede data. That would be very clear. Also, because this is a 56-year-old gentleman with a de novo metastatic disease, I would recommend germline testing for BRCA alterations as well as rarer alterations. We know that we see an excess of those alterations in this man. So this is something I would recommend, not necessarily for the patient himself right now, but for his family and perhaps also for later on when he will, unfortunately, very likely progress. Now, the two things I would discuss are, as just said by Sandy, the SBRT to the metastasis. We don't have level 1 evidence, and we are actually conducting a randomized trial in France and in Europe at the moment, so I would explain that to this patient. I'm a believer. I think that SBRT can help this man, but I don't know as a scientist, so I think it's really important to get the information and to randomize. I would be also on the fence for the stack cell. I know this is a low volume man. I know that charter does not necessarily support the use of the stack cell in these men, although this was a post-hoc subgroup analysis based on a rather small subgroup. But actually, Stampede shows very similar benefit from the stack cell in low volume and high volume men. And actually, is there really a big difference between 2 and 3 metastases, or 3 and 4? I'm not totally sure. And the one you showed in the iliac bone is rather big, so it might be actually 2, who knows? So, and this is a young man who is likely to benefit. So probably right now, I would not use the stack cell routinely, but I would keep it in my mind, and hopefully we'll have more data in the future from Arasens, PIS1, and Zamet in this particular man to try to highlight us.
All outstanding comments. And as I said, these are real cases. So this is a patient I met fairly recently. I've anonymized a little bit, so you couldn't possibly identify him from my practice. But but he started ADT and an AR pathway inhibitor, in this case, darolutamide, and we're going to decide later about the role of docetaxel. It is under consideration, but he will get, the plan is for him to have radiation to the prostate as well as to both metastases. And again, this is a real case, so it has its own wrinkles, like the MET in the pelvis is unequivocal. I think the MET in the cervical spine is real. We're going to get an MRI of that to be sure about that before we go ahead and radiate that site, because there's potentially a little more toxicity there to radiating a cervical spine. And your other comments about germline testing are spot on, and that is underway as well. So thank you for the excellent discussion. Sandy, did you have something you wanted?
Yeah, I was just going to see if you would comment on, in general, local therapy and whether this patient had, what the role of surgery would be.
Oh, yeah. That's a fine question. So in our practice, I'd say that's rarely done. I can't say it's wrong, and I think in some ways, perhaps medical oncologists above all make too much drama out of the surgery versus radiation thing. The patient needs local control. When we've done that, it's tended to be similar setting of a young patient with bad disease, but not with bone metastases, or not the need for metastasis-directed therapy. Karim, what do you think about surgery?
We do similar. I know there's an ongoing randomized trials here in the US testing the hypothesis. I don't like the control arm without radiation therapy, I have to say, given that we have an overall survival benefit shown in Stampede. We don't routinely operate on these men at my center unless there are symptoms that need to be controlled by the surgery.
So SWOG 1802 does allow not just low volume, it's all patients. And I think to Karim's point, there is a bias, a referral, especially since we have overall survival for low volume. We have had that open, and much of our referrals have been for patients with high volume disease. They get randomized to either some therapy or none, and if they get randomized to an intervention arm, they can choose between radiation and surgery.
And I do appreciate that. And Karim, I like your point. There are patients, they're not all that common, but who just really need definitive local control, and surgery can play a role in these poor patients who present with obstructive voiding symptoms, catheter-dependent, prostadynia, and so there are patients who really do benefit from that. Fortunately, it's not all that common, but that is a setting where we have selectively done surgery in patients with metastatic disease. All right, so we're going to move on to the second case. We're not going to ask for your votes right now. We're going to come back to it after Sandy's presentation. And this one has its own special features. This is a patient who had a prostatectomy in 2018. Pathology showed PT3A and 0, Gleason 4+3 with tertiary pattern 5. He had negative surgical margins. Then a couple years later had a rising PSA, negative imaging, and he had combined modality salvage therapy with radiation to the prostate bed with short-term ADT. And then in November 2021, he had a briskly rising PSA, now 3.3. Conventional imaging with bone scan and CT reported no detectable metastatic disease. And then in January 2022, PSA was 8.6, and by that time, PSMA PET-CT had become available at our center, and he underwent imaging with that. And now just again, 2 months after having negative conventional imaging, now has multiple sites of metastatic disease involving the right scapula, 8th rib, 4th and 7th ribs, T5 vertebral body, T8, and bilateral iliac bones. And I've just shown, one of the representative lesions with a yellow arrow there, pretty unmistakable, beautiful PET-CT imaging. And we're going to come back to that case after Sandy's presentation.
Okay. Thank you so much, Matt. So much has changed in prostate cancer. Today at the breast session, there was a standing ovation for the use of the HER2-directed therapy for women with low HER2. And I think prostate cancer in some ways follow breast cancer. And we used to have just ADT as the only choice for patients with hormone-sensitive disease, and now if you look at NCCN guidelines, we clearly have multiple options, all category 1, so there are clearly choices that we can make based on patient characteristics, based on patient preference, and based on the trial data. So let me just start off with where we were back in 2015. Really, ADT used to be the standard, and it was fairly straightforward. And then the whole idea of bringing in chemotherapy from the CRPC space, where docetaxel was first tested and shown to have a modest benefit, was really brought into the front line and incorporating that along with ADT. So here are two large trials. The first one was the Charter trial, which was it was a cooperative group-run trial here in the US. Patients were randomized to either ADT alone or ADT plus 6 cycles of docetaxel. And really the endpoint was looking at OS and radiographic progression-free survival. Chartered was one of the first trials that really highlighted this definition of volume of disease. So I just want to, for the rest of our talk for today, just define what high volume is. They defined it as 4 or more bone mets, with one being outside the axial skeleton or the presence of visceral metastasis. That defined as high volume. So in this, you can see that patients who were randomized to the docetaxel arm had a 13-month improvement in overall survival. I'm not showing you the high volume here, but for patients with high volume, that magnitude of benefit was even higher with a 17-month improvement in OS. So Stampede is really a remarkable design, a multi-arm, multi-staged trial design where multiple arms are added to the standard of care. So you can see that the Stampede trial, again, comparing ADT versus ADT plus docetaxel, had an improvement in overall survival of about 10 months. The hazard ratio on the Stampede trial was 0.82, and on the Charter trial was 0.61. So that was chemotherapy, sort of at that point. After leaving that ASCO presentation, I went back and I was offering my patients ADT with docetaxel. In parallel, there were these two trials that came out the following year. In fact, Karim presented the Latitude Trial looking at abiraterone, which again, similar to docetaxel, was approved in the refractory CRPC space and then moved up in earlier lines and eventually made it to metastatic hormone-sensitive disease. Latitude did have high-risk population. These are all patients with visceral mets or had a high Gleason score. And you can see a remarkable difference in overall survival by adding ABI to ADT. The hazard ratio, again, 0.62. And similarly, almost that same year, the Stampede, this was arm G, looking at ABI plus ADT, and you can see it's almost identical hazard ratios. So two large, well-designed trials, again, giving us a second option now, that for those patients who don't want to have chemotherapy, the benefit of ABI to ADT offers these men an improvement in overall survival. You could see it's almost like a 35% risk of less risk of death by getting the patients to go on this. These two trials, now we have longer follow-up, and you can see that with time, the hazard ratio is holding up. So clearly, these are drugs that are giving these men long-term benefit. Then comes, as we had this discussion now, that you have docetaxel, you have ABI, what would be the best choice for patients? The Stampede, as you can see, because it had these multiple arms, there was a paper looking at arm C, which, as I just said, was with docetaxel, and arm G was with ABI, a comparison between these two arms, because this was really a practical question that was there in front of our patient as to whether we do dosi or whether we do ABI. So this was a comparison looking at these two, and essentially there was no difference in overall survival. So you could choose either one of this, and around that time it was really these other endpoints such as metastatic PFS, symptomatic skeletal-related events. There was no difference. There was a failure-free survival favoring ABI, as well as PFS, but essentially no difference in OS. So I think practitioners and patients started having this discussion about an IV versus an oral drug, getting 6 cycles of dosi versus staying on an oral on ABI. There are reimbursement issues, but truly this was a choice that patients and providers could decide between these two. As we were getting settled with just the idea of chemotherapy and ABI, then came our next wave of clinical trials, really, looking at our androgen receptor blocking drugs, such as apalutamide in the Titan study, and I'm going to show you the trials with enzalutamide as well. So this was a phase 3 trial with a large number of patients. I mean, it's remarkable that we now have close to 9 trials with greater than 1,000 patients in each of these studies completed, showing a good data supporting the use of these drugs over ADT alone. So this trial, again, took men who were newly diagnosed. They did have a mix of patients with de novo as well as patients who had had prior therapy. There were patients with low volume, high volume. There was a mix of these patients. The patients were randomized to either ADT plus placebo or ADT plus apalutamide, and the primary endpoint was looking at rPFS and OS. Just like the previous trials with chemo and with ABI, here again with the addition of apalutamide, there was an improvement in radiographic progression-free survival. You can see the hazard ratio for rPFS was pretty impressive at 0.48 with a statistically significant p-value. And I'll show you up in the next slide the overall survival again, favoring the addition of apalutamide to ADT. You can see that the median survival has not yet been reached for the apalutamide arm. For the placebo arm, it's about 52.2 months. The next trial really we're looking at the other AR inhibitor that's been around for almost a decade now with enzolutamide, bringing it again to the earlier lines of therapy. This is ARCHES. Similar trial design like Titan. It included patients with low volume as well as high volume. There were patients now, because docetaxel had been studied and had become a standard, there were some patients who had had prior docetaxel. So you can start seeing the number of patients getting dosi in these trials slowly increasing. It's about 15 to 18%. So this is a randomized trial to enzalutamide versus placebo. Similar endpoints looking at rPFS and OS. It's remarkable how these slides, how these trials all have a similar magnitude of benefit. Again, the hazard ratio for this trial, this is rPFS, a hazard ratio of 0.39, and an overall survival, again, favoring enzalutamide. There's almost a 14% difference between the two arms in terms of the percent change in OS. Again, hazard ratio, if you think about these drugs, all of them have a similar hazard ratio around 0.6, favoring the addition of drug X over ADT. And then finally, the last trial that was run by the group in Australia, the Enzamet trial. This is a trial looking at slightly different design, because if you look at the standard arm here, it's ADT plus our standard non-steroidal anti-androgen, which could have been bicalutamide, flutamide, or nilutamide as the comparator arm. And the experimental arm included ADT plus enzalutamide. Slight difference of this trial compared to the ARCHES. Here, there were a much larger number of patients who had received docetaxel as part of standard of care. So you can look at the stratification, again, volume, high versus low, whether they had planned docetaxel or not. And then the primary endpoint of this trial was looking at overall survival. So here is a trial showing that there was improvement in overall survival with the addition of enzalutamide to ADT. Again, the hazard ratio, again, the similar 0.67 favoring overall survival. At this meeting, there was an update with the Enzolutamide trial, and I think I'll have Karim talk about it in his section. So I'll let Matt talk about the case and maybe how people poll on the results next.
Yeah, excellent. Thank you, Sandy. So we're going to move on to the case. Thanks to the audience, both in person and virtually, for sending in questions. Please continue to do so. I'll try to address some of these in the discussion of this case and then at the end with the Q&A. So again, this is our 74-year-old patient with recurrent MHSPC. He's undergone prostatectomy and salvage radiation therapy. He had negative imaging for rising PSA in November 2021, and then just a couple months later had a PSMA PET CT shown here with multiple sites of metastatic disease. So let me try to help. I think this case raises a number of really practical issues, including the issue of how do we interpret PSMA PET imaging, particularly in a patient who had recent negative conventional imaging. So Karim, how would you classify this patient, or can you classify this patient with our standard terminology?
Right. I assume that the conventional imaging was normal, even the CT component of a PSMA PET?
Yeah, so let me clarify. So in November, this is a real case. November he had, rising PSA, bone scan and CT, flat negative, just read as negative. When he had a PSMA PET 2 months later, and as you know, may not have said it, but with the knowledge of the PSMA PET imaging, they then said there were sclerotic lesions at those anatomic sites. But I'm not sure they would have called that had they not had the PSMA PET imaging, which is sort of the contemporary dilemma that we face. But so knowing that, how would you classify this patient, or what else might you like to know if it was available?
I would actually, think that this is a quite concordant case. This gentleman obviously has a bad cancer, high glycemic score, is progressing rapidly by PSA, and the PSMA PET, as you just described it to us, actually shows not only avidity for PSMA, but also a lesion that is basically very likely, to look like a metastasis on the CT compartment. So I think I probably don't have any doubt in this gentleman that unfortunately he has metastasis. So I would feel comfortable calling him a man with metastatic prostate cancer. He received, I believe, a short course of ADT a year ago, something. So
yeah, 2 years earlier,
right.
Total of 6 months of ADT.
Right.
So
we're probably missing his testosterone level, but I assume it's in the normal value range now. Okay. So I would simply call this gentleman a man with metastatic castration-sensitive disease with recurrence from a local primary, and I would agree with most of you guys voting and supporting ADT plus an AR pathway inhibitor. Discussion would be indeed whether those men receive or need to receive docetaxel chemotherapy. 74-year-old, you need to be cautious with chemotherapy. I don't know exactly how is clinically, whether it's a bit frail or not. I mean, those are questions we need to answer. And again, question about radiation needs to be addressed.
Yeah, so all good points. So I'm going to push you a little harder and say, would you call him high volume or low volume, or is it just can't be classified because of the nature of the imaging?
Well, it's probably too easy because you told me that the CT actually shows a sclerotic lesion. Mm-hmm. So basically, I would feel comfortable calling him, probably a low volume man because this was a unique lesion, I believe.
So he had actually, I showed one. He actually had about 7 or 8.
Oh,
lesions.
sorry, I just saw one. Okay.
In the picture, I only showed one because I couldn't get them all on the same slice.
Okay. Yes, well, regardless of all the verbiage, low volume, high volume, I think the benefit should, how do you say that? The DOP should benefit the patient, simply.
Yep.
So in any of these cases, if we have evidence showing better outcome with the X treatment, if we believe this is low volume or high volume, we should propose those treatments to these patients when we are on the fence for the definition. So here, maybe indeed, if there are 7 lesions, I may indeed intensify him with a triplet systemic treatment, indeed.
Yeah. Sandy, do you agree?
I don't know. I have a slightly different take. I do want to remind my colleagues, as well as all of you in the audience, that all of the trials that I showed only included patients with conventional imaging. So in some ways, our imaging is ahead of our clinical trial data. I think that's really something to point out. But having said that, clearly this patient has metastatic disease. He has a very rapidly doubling PSA doubling time. So it makes sense that these Mets are real, and he has a rising PSA, which is a marker of microscopic disease, but now you have radiographic imaging. So I agree that I would treat him as metastatic disease. I don't know about high versus low volume. He doesn't have any visceral Mets. At least from what you had mentioned, it didn't seem like there was anything outside the axial skeleton.
There was not.
So I don't know. I think if you go by the definition, it feels like it is low volume. And ADT plus intensification with then hormonal drugs seems like what I would offer this patient.
Yeah, I've intentionally tried to be unfair to my colleagues and push them into classifying this in a binary way. I mean, risk is, of course, a continuum. High and low volume are just dichotomous variables. And they certainly have an important value in patient selection for clinical trials, but in our daily clinical practice, we need to make more nuanced decisions. So while I've been a little unfair with you in trying to force you into naming it, I think we would all readily acknowledge that there are going to be subtleties involved. There are some other high-risk features in this patient. He had tertiary pattern 5. He has a rapidly rising PSA. These lesions, although weren't seen 2 months earlier, they did have CT correlates. And the other part is, and Karim had mentioned this, is the age and health of the patient. This guy's 74. He's fit, medically fit for chemotherapy, not mentally fit for chemotherapy. He just had a really difficult time accepting this diagnosis, and it was sort of all we could do to get him on systemic treatment. And he was also had other personal things, including travel to, as many of our patients in the Northeast do, we call them snowbirds. They leave for the south to Florida in the winter, and that's what he was doing. So we treated him with ADT and Enzolutamide rather than abiraterone, partly because of just lesser requirements for return visits to see me during his treatment. And after discussing the nuances about adding a third drug, docetaxel, he elected not to do that. But this case, again, has some nuances, as many of them do. So I don't. It's a good question. I'd say I would have a conversation with him. This isn't someone who I would do any arm twisting to do. If we change the circumstances and make the same patient 56, like my first case, then I would really encourage them to do chemotherapy. So there were the practical reasons is he was traveling for much of the time, but the other part is he wasn't, say, prepared to accept. It was very psychologically challenging for him, the diagnosis and the treatment we'd already proposed. So he was just not willing to consider chemotherapy. And I don't think we're in a place to twist his arm to do that. And we're going to hear a lot more about triplet therapy from Karim in a few moments. So we'll get more into those issues. But thank you for that. So I'm going to try to address a couple questions that we got in. One is, how has PSMA PET changed how you select therapy plans? I mean, we kind of covered some of this, but are there other ways you think about that, Sandy?
I mean, mean, I think it is quite challenging because we've been doing PSMA PETs for a long time, even prior to its approval. So we have had many isotopes that have been looked at. So have some experience with it, but it's always a challenge because, again, all of these trials were done with conventional imaging. So are we really making people live longer by treating them sooner? We don't know, but it's very emotionally challenging once you have done the test and you see all of this. I think it's hard for you as well as the patient not to really act on it. We know a lot more, I think, about PSMA in the localized setting where based on trials, it's changed treatment decision, right? So some people have, who were intended to go through surgery, didn't get it done because they were far more widespread disease. I think in the metastatic hormone-sensitive space, there are trials that are needed really to know whether we are going to have the same impact of longevity by starting them now.
So Karim, how do you think about the lead time bias that PSMA PET introduces, or just reclassification? So now a hypothetical case, negative conventional imaging, or just has PSMA PET CT, but now he's got multiple, 3 to 5 millimeter retroperitoneal nodes, high Gleason grade from prior prostatectomy, rapidly rising PSA, but there's no CT correlate. How would you typically manage such a patient? Would you manage him as metastatic disease, or what other information would you want to have to make that decision?
I think medical judgment should play its role, really. In the first case, or best case actually, that you just showed, I think everything is quite concordant. Mm-hmm. He had a bad Gleason score from the beginning. He relapsed rapidly. At the second relapse, the PSA doubling time was fast. And out of a sudden, of course, the PSMA shows multiple lesions, 7, you said. So there's no, discrepancy. So I think in those cases, we should probably treat, and again, this is opinion, I recognize that, but we should probably treat this man as almost if the conventional imaging would show similar findings. Probably because if you don't treat them right now, in 6 months or 12 months from now, actually the bone scan will show that. So I think that makes sense. And again, this is opinion. We don't have data. Now, if for any reason there is a discrepancy or something a bit difficult, and in this last case you mentioned, if it's lymph node disease only, of course, you need to be more cautious. There are also false positive and false negative with PSMA PET. So we just need to do our best to try to figure out what we're doing, and especially if another imaging possibility is available, we should probably do it. Sometimes we can biopsy, and we should not forget that. It actually can help and tease out those false positive. And at the end of the day, you're making your medical decision.
Thank you. Sandy, I have a quick question for you, and that came from the audience, and that is there a role for treatment interruption? So I guess the question is for you is, we have this information about systemic treatment intensification, but are there patients where you would intensify treatment but then do it intermittently, or are they just, because they have a bad enough prognosis to warrant treatment intensification, is it such that you would not interrupt their treatment?
I think in general, this question about intermittent versus continuous have been done with just plain ADT alone. And in the metastatic setting, really, discontinuation was not non-inferior. So continuous therapy has been our standard. With these new drugs, I think the norm has been just to continue, and unless the patient either has a dramatic response or you have reason to stop because of tolerability issues. Rarely it has, some of these drugs, with AbbVie, sometimes liver enzymes is an issue. With Enzolutamide, sometimes fatigue can be quite an issue. So we attempt at dose reduction, but occasionally stoppage again, these are all, there's so much patient engagement in all of this that I think it's a shared decision. Based on the data we have, I think that what we would tell patients is to be on continuous therapy.
I think all great points. And it also raises the other point where we need more information is about the role of metastasis-directed therapy, where I think intermittent therapy can become attractive if you've been able to radiate all identified sites of disease, particularly for patients who have a undetectable PSA nadir. It's certainly tempting to consider discontinuing all of their systemic treatment. So thank you for the great discussion to my panel, and we'll go on to our third case. This is a 63-year-old man with de novo high volume MHSPC. He presented with recent onset of diffuse bone pain. Imaging reported extensive bone metastases. His DRE was abnormal with bilateral palpable abnormalities. PSA was 9.6. Prostate biopsies reported extensive Gleason 4+5, and bone scan shown on the right shows extensive metastatic disease. It's a super scan with no renal excretion of contrast. And so we're going to come back to that case after Karim's presentation.
Sure, thank you very much, Matt. So we've learned that indeed we should intensify treatment with at least a second treatment. The question is whether we should do 3, maybe 4 in the future. Let's see what we have. So again, it all started with, and Sandy alluded to that, back in approximately 2015 with docetaxel, then 2017 abiraterone, and then we had confirmation with other AR-targeted agents such as enzolutamide, apalutamide, and then actually darolutamide, and today another drug coming from China also reported overall survival improvement in the similar setting of MCSPC. So it's very clear that those agents work and that we should use them in the setting of CSPC. Also today, we saw an updated analysis of Enzamet, and Enzamet again was randomizing standard of care plus or minus enzalutamide. And standard of care could consist in ADT plus bicalutamide, but also in some men, docetaxel chemotherapy, and I'll come back to that. With longer follow-up, the benefit is maintained, as you can see. The hazard ratio is 0.7, so 30% reduction in the risk of death with enzalutamide. Curves separate very nicely. Also, something very important is really the debate around low volume and high volume. And actually, my opinion is that we're perhaps making too much of it. If I'm looking at other cancers, I don't actually really see other cancers where we're thinking so much about the burden of metastasis deposits before making a decision. Maybe kidney cancer because of the local treatments we're using against metastasis. But when it comes to systemic treatments in whatever you like, colorectal cancer, lung cancer, etc., we don't necessarily count the metastasis before we're making a decision. We're trying actually to look at the biology of metastasis, which is much more interesting, I think, and insightful. But anyway, people really like to see low volume and high volume. But again, I think we should be more cautious about that, and it's actually probably more a continuum. Having said that, I have to recognize that when it comes to localized treatment of a primary, we now have quite clear evidence, as just shown by Matt, that indeed only patients with low volume disease benefit from radiation directed to the primary. In terms of overall survival, what we actually don't really know is whether high volume men may benefit in terms of local control of the disease regarding symptoms. Hopefully we'll be able to address that in piece 1. Now, regarding systemic treatment and the volume, again, there's been debate as to whether docetaxel benefit to both high volume men and low volume. And actually, it remains an open debate, I think, also because in Charted, for example, there was a mixed between patients with de novo disease and relapse. And actually, a man with oligometastatic relapse usually do well. So these men may actually not need the Taxol intensification, while actually oligometastatic men, de novo, don't necessarily do well, as just shown. Anyway, regarding the next generation AR targeted agents, they are obviously active across the board. So you don't necessarily need to count the metastases to decide whether you should use one of them. And this is true across the board. I just provided some example here. Abiraterone, apalutamide, and enzalutamide actually provide overall survival benefit, whatever the number of metastases. So you can make it easy for you and for your patient. Sandy already alluded to that. Between, again, 2017, when we started to have the first AR data with abiraterone, and last year, before we had the first data from the triplet, there was debate as to whether we should use the Taxol chemo or one of these AR agents. And I've tried to summarize here the results between this match, indirect match, I have to say, because those are mostly indirect comparisons. But for progression-free survival, it's quite clear that next-generation AR targeting agent do better as compared to the Taxol chemotherapy. And actually, this is also supported by direct analysis, direct evidence from Stampede, where the patients were directly randomized between abiraterone and the Taxol, and PFS was actually much better with abiraterone. This also was the case for quality of life, and also, and this is something maybe oncologists don't really know, also pain control, symptoms. Many of my colleagues, or my oncologist colleagues, think, okay, this poor gentleman is full of metastasis. I should hit strong the cancer with chemotherapy. Yes, but actually, when you have a strong oncogenic pathway, an oncogenic addiction, and you have a good weapon to hit it, it usually works against symptoms also. And this is the case in prostate cancer, where the androgen receptor is a very strong oncogenic pathway. And actually in Stampede, when randomizing the Taxol versus abiraterone, the efficacy against symptoms was greater with abiraterone as compared to what was achieved with the Taxol. So it's not only quality of life, it's the anti-cancer effect. The toxicity profile is usually better with a hormonal agent as compared to the Taxol, at least the immediate toxicity. And I have to recognize that we are basically comparing apples and pears here, because it's just not the same toxicity. Overall survival, I think the jury is out in the Stampede analysis that Sandy just showed us, because the analysis was performed after just 2 years of follow-up, when most of these men were actually alive. So we cannot really tell. And when we're looking at indirect comparison, with all the caveats, of course, we have probably 10 trials now, and they all show the same data. And I think Sandy already alluded to that. AR drugs, 35% reduction in the risk of death. Chemo, 20% reduction in the risk of death. So of course we're not totally sure this is a true finding, but when 10 trials are reporting the exact same finding, it probably means that it's a true thing. So I do believe that OS is actually better with a next generation AR inhibitor as compared to the Taxol, and I recognize that we don't have direct evidence to say that. Having said that, the cost is in favor of the Taxol, at least in my system, where the Taxol is super cheap, it doesn't cost anything, and the hospital is actually covered by the public systems. And of course, we have to adapt cost analysis based on our national systems. So in this match, I would choose an AR drug as opposed to the Taxol, of course, assuming this is available. But we now have, since last year, we have triplet data. So not only the Taxol or an AR agent, but actually both. We first look at this equation in PIS1, and PIS1 I think is a very pragmatic academic phase 3 trial in men with de novo metastatic castration-sensitive disease, we're basically asking two questions. Number one, should we use abiraterone on top of standard of care, which was mostly ADT plus docetaxel? Number two, should we keep using radiation therapy when we are intensifying all systemic treatment? We know that from Stampede with ADT alone. The primary endpoint, the co-primary endpoints actually were RPFS and overall survival. For the radiation question, don't ask me, because I don't know. We haven't analyzed it yet. By our pre-planned statistical plan, we need to have enough events in the low volume population before we can start the analysis, hopefully in a year from now. But for the abiraterone question, we do have the data since last year. And I guess the news are good. Indeed, when adding abiraterone on top of ADT plus docetaxel, we see a quite tremendous difference in radiographic progression-free survival, medians 2 years in the control arm and 4.5 years in the experimental arm with abiraterone. So in other words, you're providing 2.5 years of good life to your patients without progression. Hazard ratio was 0.50, and this is highly significant, obviously. Regarding overall survival, we had to be patient last year, but we could report that at ESMO, and this is now published. And again, the news are good with overall survival improvement when 3 drugs are used instead of 2. And this is true in the overall population, as you can see on the left-hand side of the slide. This is even more true when you're looking at the docetaxel population, so patients receiving ADT plus docetaxel plus or minus abiraterone. And the overall survival also includes some patients who had ADT alone as the standard of care at the beginning of a trial before docetaxel has established its role. So I think this was probably, well, not probably, it was the first trial to show that 3 drugs are better than 2. What about safety? Because this is all nice, but intensification can come with more side effects. But I think this was also the good news that we had in the trial. Basically, what we found with 3 drugs was that hypertension was seen more frequently, 22% versus 13%, as expected, to be honest. And we also saw an excess in transaminase increase, which is, of course, very well known with abiraterone, but honestly, nothing really bad. It was pretty much 6% versus 1%. And all the rest was really even, especially the toxicity of chemotherapy was not increased by abiraterone. For example, febrile neutropenia was exactly the same in incidence, and neuropathy was also totally similar. So this really was a good news, because I was, of course, afraid of additional toxicity. This is now supported by data presented by Matt at ASCO GU regarding the ARASENS phase 3 trial. And this is probably the purest trial looking at this question of 3 drugs versus 2. And I'm saying that because all these men had actually received ADT plus docetaxel as the backbone treatment, and half of them were randomized to receive darolutamide on top of ADT plus docetaxel. Big trial, almost 1,300 men were randomized, all of them having MCSPC again. Good performance status, PS0 or 1. Primary endpoint was overall survival. We don't have RPFS data in ARASENS. And again, news are good with a very clear overall survival improvement favoring the combination arm with darolutamide. Hazard ratio was 0.68. So in other words, a 32% reduction in the risk of death. And you can see the Kaplan-Meier curves, they separate quite fast, and the more the time, the better the difference is greater. This came together with key secondary endpoints also favoring the darolutamide arm, for example, time to CRPC. And actually, this is important for patients. None of my patients really like to experience a PSA increase. I mean, it's a biomarker, but it's a terrible biomarker psychologically for patients. They just don't like, and I can understand that, of course, they just don't like to see their PSA rising. Look at this difference. This is really big. And again, indirectly, you're providing good life to your patient because they know their PSA is under control on top of their symptoms and imaging if you do that. Also, symptoms were improved, and you will see here to the right-hand side, time to pain progression, again favoring the darolutamide arm. What about safety? Similar to what I said for PIS1, you just don't want to harm too much your patients with additional toxicity. And as you can see here, or maybe you cannot see it because it's too small and too many side effects were looked at, but actually there is no real difference between the two arms. If the only small and tiny differences that we could showed were included hypertension, 6% versus 3, and also transaminase increase, which is quite rare, approximately 3% versus 1 or 2, but all the rest is really even. And darolutamide is really well tolerated. This is what we found already in a previous randomized trials in M0 CRPC men, and this is now confirmed in a RASENS for these men. So again, that's great news, and we don't really seem to see any drug-drug interaction with docetaxel or other agents. So at this ASCO, you will see more data regarding RASENS. For example, Psa Response was assessed and analyzed, and actually the correlation between response and overall survival has been studied by Dr. Saad and colleagues. Clearly, the magnitude of response is greater in men receiving darolutamide in the trial. And also, and again, because this is not new, there is evidence that PSA value, say at 6 to 8 months, predicts future outcomes for these men. Very clearly, you see here 24 weeks data and also 36 weeks data. Hazard ratio is pretty much 0.4 for an undetectable PSA. This is not only important for you as physician, because I guess we're all happy when we see a patient with an undetectable PSA, say at 6 months or so, because we know this is predicting a good outcome for this particular gentleman, but it could be also important for future research because it provides us potentially situations where we may de-escalate treatment for patients responding tremendously, of course in the context of clinical research. And on the other hand, in patients with detectable PSA at 6 to 8 months, we may actually further intensify those men with, I don't know, PSMA targeting, PARP inhibitors, whatever. But we know that these men with detectable PSA at this time don't do well. So it's probably a right time to intervene only. Again, we don't have evidence for that. We just saw also today the updated analysis of enzymatic, as I just said, and this is the sub-analysis that was provided earlier this morning. I won't go into too much detail because actually I think there were too many sub-analyses shown today. But I think what was clear was that metastatic synchronous disease treated with docetaxel seemed to benefit from additional enzalutamide. And this again supports what was found in PIS1. We don't have this analysis yet in a RASENS. Hopefully we will do that. So this will be interesting. And this is probably supporting the case of a triplet intensification, at least in these men who have de novo metastatic disease and who are fit enough, of course, to receive docetaxel chemotherapy. So my take-home points for today. are as follows. For men with de novo disease and a high volume who are fit for docetaxel chemotherapy and willing to receive chemotherapy, we probably should recommend ADT plus docetaxel plus an AR drug, either abiraterone prednisone or darolutamide, assuming this is approved, or maybe enzolutamide based on what we've heard today. For men who are unfit for docetaxel, by default, we should probably go for ADT plus one of these NHTs. Now, in men with de novo and low volume, I would say at least ADT plus an NHT plus radiation directed to the primary should be our standard of care at the moment. And we may actually discuss triplet therapy on a one-by-one basis, especially in young patients who are fit, obviously, for chemotherapy and who have bone disease. Again, what is really the difference between 2 or 3 metastases and maybe 4 or 5? I'm not sure. So, especially if it's a big one, those are potentially scenarios where I would consider discussing with the patient triplet therapy with docetaxel. Regarding patients with a relapse, either low volume or high volume, probably ADT plus an NHT is the current standard of care. Having said that, I recognize that we sometimes are facing patients who are very frail or very elderly. A 90-year-old guy might not be a good candidate for intensification. So again, in these men, maybe by default, we should keep using ADT alone, but this is a small subgroup of men. Most of them should probably get intensification. And as I just said, there is still room for better treatments and perhaps even further intensification. PSMA targeting should probably be studied and is actually studied in the setting, and I think data will be welcome. We need to see whether we can improve patients' outcome, but also we should make sure we're not harming patients. So please don't do that outside a clinical trial. And on the other hand, we may actually de-escalate treatment. We just spoke about it with Matt. In patients responding tremendously, do they really need to be exposed continuously to an AR drug? I'm not sure. So those are things we should ideally assess in clinical trials. And finally, I think we spoke about it already, but I would like to emphasize that again. We probably need to use germline genetic testing in men with metastatic disease. And I'm saying that because there is clear evidence that the incidence of BRCA alteration, germline alteration in these men, is higher as compared to the general population, and actually higher as well as compared to localized disease. So this is actually my practice, actually recommending germline testing in these men. For somatic testing, we now have targeted agents with PARP inhibitors, probably also immunotherapy for MSI high patients. So those are good reasons to consider somatic testing, but probably this is more for mCRPC. And Matt, I think I have to leave you the floor for this gentleman.
Yeah, thank you very much for that terrific overview and outstanding comments. So let's come back to our case. So this is a 63-year-old man with de novo high volume MHSPC. PSA was only 9.6. He had extensive Gleason 4+5 and most importantly, extensive bone metastases as shown on the super scan here. So we had a few really good practical questions just about clinical management. And I'll begin with you, Sandy. Says, how do you help your patients handle 3 therapies? Don't they feel overwhelmed?
It is. I think, the discussion now for patients with newly diagnosed disease has become quite complicated. First you're breaking this bad news that they have metastatic disease. Then these are men who have normal testosterone. So you're going to have to talk about what it means to get their testosterone down. And on top of that, talk about the side effects of AR targeting therapy and then chemotherapy side effects as well. So it's one thing about about the time and the education that's needed to help these men get comfortable. The second is logistically, it's really a challenge to get all of these approved. You know, for patients coming in, we clearly need time to get authorization for our oral drug, which typically takes, at least if you're lucky, we get it in 2 weeks. Chemotherapy can be done a little bit sooner, so it's also a lot of logistical challenges in trying to get this all outlined. We need help from our nursing education team. I mean, patients need a lot of emotional, physical, and financial support to get through this. And it's also what do you do first? So the way I think about it in my clinic is I start with an LHRH antagonist. That way you don't need to think about the flares that can happen with an LHRH agonist. So I do that for the first month. Get them, if the patient is chemo fit, and I've spoken about chemotherapy and it's our shared decision that the patient agrees, I start with chemotherapy first and then put in this authorization to get the oral drug, and when that becomes available, sort of just stagger it so that it's not all thrown at them on day one.
Yeah, so thanks for that. I take a somewhat different approach. I mean, I think the concept is the same. And when we teach our fellows, I actually say this, when describing the patient's anxieties or fears, I ask, is that really the patient or is that the mirror? Because a lot of the anxiety is ours, right? I mean, and early when we had this early evidence for intensification, I used to consistently tell patients, well, this is what we used to do. We give ADT, but now we have this evidence of intensifying treatment. A patient diagnosed in 2022 doesn't care about how we used to treat prostate cancer 5 years ago, right? This is their only experience. So I try to make it simpler, and I simply say, you need hormone therapy. For a patient like case 3, you need hormone we can all agree almost every patient with MHSPC should get an AR pathway inhibitor in addition to ADT. So that's their hormone therapy. And some of them, particularly high volume de novo, should get chemotherapy. So I make that the 2 conversations. You need hormone therapy, and for the high volume patients, we're going to have a separate discussion about your chemotherapy. And I take a little different approach than Sandy, and I just start their injectable hormone therapy, their GnRH agonist or antagonist, and prescribe the AR pathway inhibitor on day 1. There's no drama about it. So it actually is, I think, easier for patients to accept. And we also heard from Karim that the tolerability profile is actually quite favorable, particularly for darolutamide, arguably for the other drugs as well. So generally pretty well tolerated. It is a lot for patients to accept. They're hearing they have a fatal disease. Now they need 3 therapies. But in a way, it's really hormone therapy plus chemotherapy for some. So I think that makes it simpler. We had another really good question, practical question. And the 3 of us have kind of a lot of personal experience in treating primarily or exclusively prostate cancer. So one is just really, what is the expected PSA profile after starting, say, triplet therapy or doublet therapy? Karim, can you answer that? Like, what should the clinician who maybe doesn't have a lot of experience treating prostate cancer expect to see with the PSA, and how do you use that information to make subsequent management decisions?
Well, PSA has its limits, but it's actually a pretty good biomarker, to be honest. It's not telling everything, especially, for example, in this gentleman who has a quite low PSA as compared to the burden of the disease, 9 or 10. We may be cautious on that one. But generally speaking, PSA is telling us most of the story. So as I said before, for example, assessing PSA at 6 to 8 months is a very strong predictor about what's next. So I'm not necessarily sharing this information this way to my patient because I don't want, unless they have an undetectable one. But still, this is something that can inform yourself regarding the surveillance process, for example, and how strong you may image this gentleman. What else can we say about it?
I think the other thing I would add, and there's actually data at this meeting, I can't remember from which study it was, it may have been, Arches, thank you, and this is the same observation that was made in the NMCRPC studies, very important point. On patients who are on an AR pathway inhibitor, they have radiographic progression at substantially lower PSAs than patients who are on ADT alone. It was quite dramatic in ARCHES. I think radiographic progression occurred at a PSA of about 1 compared to 14 in patients who are on placebo. So that is worth noting, and it makes some case for a role of, imaging, well, I would say at a low threshold. So I will image patients who are on an AR pathway inhibitor for basically any confirmed PSA rise or doubling of PSA, even if it's at a very low value. And some might even extend that further to say there should be, sort of imaging based on the calendar, even in patients with a lower undetectable PSA. Candidly, I don't think there's very many patients who have true PSA negative radiographic progression. It's just that they have radiographic progression at much lower PSAs.
I think I would just add, Matt, at this most recent version of NCCN, we actually made a very strong case for incorporating imaging and not just rely on PSA alone.
Yeah, I think it's a fair point and supported by the data. The subtlety I was trying to make is, in my personal practice, I think it'd be very rare to see true radiographic progression with at least an undetectable PSA or no PSA progression. Sandy, how do you think about imaging? What is your choice for follow-up imaging? Do you have a preference for what form of follow-up imaging you do? This came from a question from the audience.
Well, I think it depends what's available to us, right? So I think you have a choice of your conventional imaging, bone scan, CT scan, I think would be the easiest and the cheapest. But now we have tracers such as Axiom and fluciclovin PET scan, and we have the availability of PSMA as well. Want to think a little bit about being cost conscious as well, about what the value add of those scans would be. So I typically depends on what the starting point is. So I don't think every patient with hormone-sensitive prostate cancer needs a PSMA scan. There would be a place for it, but I think I tend to do either a CT bone scan or an fluciclovin PET.
Yep, that's fair. So I think that your point is, I usually stick with the same imaging. So case 2, where his disease was really first identified by PSMA PET CT, I would stick with that for follow-up. Case 3, unequivocal extensive metastatic disease by conventional bone scan. I would find no need for PSMA PET CT unless you were using it to assess eligibility for PSMA targeted therapy. So I think we have a few concluding things. So we've talked a lot about treatment intensification, and as you are all aware, ADT alone has some side effects, many of them listed here. AR pathway inhibitors have side effects, docetaxel. I think this slide is meant to be a placeholder to remind all of us that we really need to think about survivorship and the practical issues that matter to patients, including their quality of life, as we consider intensification. While many of these drugs, they are pathway inhibitors in particular, are generally well tolerated, they do have their risks for side effects, and Karim very nicely described, and Sandy nicely described the issues of hypertension, for example, really across all of those drugs, as well as some additional side effects with specific agents. This is important to consider. We're all, I think, duty-bound to take on these issues of survivorship and to help our patients manage these issues. I recommend, in addition to the own teaching you provide, to share reputable resources with patients. There are a number of great websites out there: Prostate Cancer Conditions Educational Council, PCEC, US2, Zero, American Cancer Society, Prostate Cancer Foundation. NCCN has great guidelines for clinicians. They also have, for many diseases, including prostate cancer, very useful guidelines for patients. So PCEC, for example, has a long reputation of advocating for patients. They provided outreach to patients, to medical professionals, to the media. Their website is listed there, so I can consider looking at that resource among the others, both for your own uses and to share with your patients. PCEC, for example, has free resources, including one-to-one patient navigation and support, educational resources, good resource for trial information for appropriate patients. This also reminds us that we're 3 medical oncologists here, and many of you in the audience are medical oncologists, but we talked about a lot of things today that involve the care that goes well beyond the medical oncology. We need our colleagues in radiation oncology to consider treatment of the primary as well as sites of oligometastatic disease, close collaboration with radiology, nuclear medicine as we think about the role of radiopharmaceuticals in the management of prostate cancer, and of course the critical and central role of urology in the care of our patients. So we have, I think, just a few minutes for questions. The question is, should race be considered, particularly African American men, as they're at greater risk for prostate cancer and prostate cancer death? Should they be managed differently than their non-black counterparts or white counterparts? Sandy, do you have thoughts about that?
I mean, I think for sure we need to be focusing more on trying to recruit African American men into clinical trials. I think that's a huge endeavor that we should all be doing. That's number one. I'm not sure about trials specifically for African American men with AR-targeted drugs, but there have been trials such as Sipuleucel T, for instance. There's been some, I mean, we don't use it that much, but it is a life-prolonging therapy. And there was a subset of patients, African American men, who had a better outcome compared to even Caucasian men. But I'm not aware of specific differences in our trial population about difference in outcome.
Yeah, so while black men are disproportionately affected by prostate cancer, they tend to be underrepresented in clinical trials. When it's been, that makes it challenging to look at those subgroups. We did look at it in ARASENS, results to be presented, but in other trials as well. And when it's been looked at with all the caveats of small subgroups, the treatment effects are the same. So I would say that in my practice in Boston, we certainly consider race, but not as a more I think less as a disease characteristic, because the disease characteristics are the disease characteristics, right? You're right. Black men tend to present with more de novo metastatic disease, higher Gleason's grade, worse prognosis, but it does present some other practical challenges just in patient management because of a long checkered history of the medical community in the lives of black men. We just have to really work on building trust so that they accept our recommendations. And I think that's just an important practical part of it. But I'd say in terms of in terms of the medical recommendations, tends to be based primarily on their disease characteristics. Kareem, do you have anything to add?
The Taxol needs to be used cautiously due to metabolism differences. And I know that many of my colleagues from Asia or Australia, and I do actually the same, tend to start the Taxol with a lower dose, at least up front, to avoid the toxicity and strong toxicity in these men. Also, there are discrepancy regarding the data, but at least some data supporting that patients from Asia may have more hormonal sensitive diseases as compared to others, but this is not fully established, so we need to be cautious about that. But regarding men with black skin, we tend to treat them really the same.
Yeah, that's been our approach, and it's more the cultural issues that are region specific or very local. So thank you for your thoughtful question, and I guess make the further point that what we really should be encouraging is greater and broader clinical trial participation. So that brings us right to the close of our program. Thank you very much to our live audience as well as to the many folks participating virtually. I hope you have a good rest of your evening. Thank you.
Thank you for listening. Download materials and complete the post-test for instant credit at peerview.com/UDM860. This activity has been supported in part by educational grants from Astellas and Pfizer Incorporated, Bayer Healthcare Pharmaceuticals Incorporated, and Janssen Biotech Incorporated, administered by Janssen Scientific Affairs, LLC.